Okay. Hello, everyone. Can you hear me now?
Yes.
Okay. I'll have a short presentation about the development of the diagnosis technology of coronary artery, which called caFFR and caIMR. Firstly, here is the advantages of our caFFR, which is also based on the contrast FFR. It has no need for wire manipulation and no need for hyperemic stimulus. It's no need for additional surgery and manipulation, and we can get the real-time SSR. This is the method that how we get the caFFR. Firstly, we use two different positions of angiography, and then we can obtain a 3D model of the target vessel. And we can get the blood velocity by TIMI frame counting. And together with the real-time aortic pressure and the optimized CFT, we can get the caFFR value. Here are some recommended image application of the target vessel, like LAD and LCX and RCA. We also need a pressure acquisition device to match our device. This acquisition device is a dedicated pressure sensor of our flash pressure. We can get real-time pressure. We can get real-time pressure and automatic matching of the radiographic images, and the pressure data can be transmitted and it is also a one-key automatic exhausted and zero calibration function. It has high pressure protection function to prevent backflow of the contrast agent. Here are some graphic expressions of the principles of our device about the fluid mechanics. This is the 3D model of the target vessel. You can see that the degree of stenosis of the target vessel. Okay. This is some clinical performance of our caFFR. This clinical trial called FLASH-1, and it is completed. It is completed in December of 2018. There are 328 cases in total. The main purpose of this trial is to use FFR as a golden standard to evaluate the diagnostic consistency of caFFR and FFR in hemodynamically significant stenosis lesions. You can see that the result of this study is very good because the diagnostic accuracy of our caFFR can be 95.7%. Here are some other data of the study. This is another study which is cooperated with Beijing Hospital. This one is to show the correlation and agreement between pre-PCI invasive FFR and caFFR. This one is the same as the last one. This is the Kaplan-Meier survival curves according to the post-PCI FFR and caFFR. This is a collaboration with Hong Kong Queen Mary Hospital. All of these studies show that our caFFR has very high accuracy compared to FFR. So here comes to the summary for caFFR. The advantages of it is no need for wire manipulation, no hyperemic stimulus, no need for additional surgery and manipulation, and we can get real-time FFR. Also, it has some limitation because the left main ostium lesions and myocardial breach will affect the accuracy of critical lesion diagnosis. Okay, now come to part 2 about IMR. Here are some consensus comes from the myocirculation expert in diagnosis. So IMR is defined as equals to PD times by TMN under maximal hyperemia. It can be used in some regions like abnormal stress study and angina, but has no significant epicardial or coronary lesions, which called INOCA. It also can be used in successful PCI but ongoing angina, and after PCI in patients presenting with acute coronary syndrome, and some patients after heart transplantation also need to be measured their IMR. This is how we measure the CAIMR, which is quite similar to caFFR. You can see that we use two angiograms from two projections, and then we can get the flow velocity, and together with the aortic pressure wave and our optimized CMD model, we can get the accurate CAIMR value. Here is a retrospective study for assessment of CAIMR. There are 56 cases in total and 57 blood vessels in total. The data is collected from Beijing Hospital, PLA General Hospital, Peking University First Hospital. The purpose of this study is to using IMR as a reference standard. The diagnostic consistency of CAIMR and IMR in patients with stable or unstable angina without obvious stenosis was evaluated. Here is data about the study. This figure is the study flow. It's just how we operate this study. This figure 2 is the case in examples of angiography-derived physiologic indices. You can see the traditional IMR image and our CAIMR image. The figure 3 is correlation of angiography-derived IFR and IMR with invasive FFR and IMR in diagnostic cohorts. You can see the very high consistency of them. This figure 4 is cardiac death or heart failure admission at 10 years from index procedure according to angiography-derived IMR. Figure 5 is incremental prognostic value of angiography-derived IMR over clinical and angiographic factors. So here comes to the summary for CAIMR. It is also no need for wire manipulation, which is more stable than pressure guide wire. It's also no need for hyperemic stimulus, no need for additional surgery and manipulation, and we can get the real-time IMR. The effective combination of CAIMR and caFFR will significantly improve the macro and micro functional diagnosis of myocardial ischemia. Okay, thank you. That's all.